Hello everyone, and welcome to a new session of learning today. And today, my topic is something which is very simple. It's not going to be very complicated at all, and it's hopefully going to finish fast. It's a very common presentation in the PICU, especially with CCF, without CCF. Yes, definitely, most of the postgraduates would have seen this. This topic for today is myocarditis. Okay, so myocarditis we are going to talk about. All right, so firstly, I'm going to just say कि myocarditis simply means inflammation of the myocardium. All right, now we'll be learning this under few headings, and the source of this is cardiology textbook, Park's cardiology textbook. Okay, so needn't worry about the source, and it's quite what can you say, it's not so detailed, but very crisp information is given, and you can just retain this. Okay, so first, coming to the prevalence, in the heading prevalence of myocarditis, what you should be knowing that is actually the clinical recognition is rare. Means you are missing a lot of cases of myocarditis. Okay, so basically mild cases, okay, mild cases are more in number, and these tend to be subclinical. Means what? You're not able to pick them up. All right, so subclinical cases are more, mild cases are more, and clinical recognition is rare. This is the only thing which you need to know about the prevalence part. Coming next to the pathology, in the pathology what we'll be talking is like how it exactly happens, and and how it looks histopathologically and what could be seen. Yeah, so if let's say the most common cause, if we take, that is a viral myocarditis, it's basically the result of cell mediated immunological reaction, right? Cell mediated immunological reaction. Okay, and when you see in gross examination, when you see the heart, the myocardium on gross examination, in gross examination you will find it as inflamed, soft, flabby, pale. These are the three words used to describe. Soft, flabby, pale, inflamed myocardium can be seen, and there will be areas of scarring, with areas of scarring. Okay, when you come to microscopically, histopathologically or microscopically, what you will see? You will see patchy infiltrations. You will see patchy infiltrations by plasma cells, by mononuclear leukocytes, okay, and sometimes eosinophils. Okay, and this is in acute phase. All these cells come in acute phase. Now suppose in later stages you see, what will happen? Definitely you'll see some kind of giant cells in more later stages of myocarditis, microscopically. Okay, so you have understood a bit about the prevalence and the pathology, and gross and microscopically how does they appear. Okay, and now coming next to etiology, very beautifully, like I always say, we can divide the etiology into infective causes, non-infective causes. Infective and non-infective. Okay, now as we know, infective is more common, so first I'll talk about that. In infective also, you know that viruses is the most common. Most common is viruses. What are the viruses? Adenovirus, Coxsackie B virus, okay, echovirus. ठीक है, these are the more common ones. These three are the more common ones: adenovirus, Coxsackie B virus, and echovirus. Other viral causes could be poliomyelitis, very interesting, poliomyelitis, mumps, measles, rubella, CMV, CMV, HIV, arboviruses, influenza, okay, influenza. So all these viruses are also there. So this comes under viruses. What about the other infective causes? Like this I told was viruses. Non-viral causes, non-viral infective causes come what? A very prominent, I'm very prominent one would be Chagas disease. Chagas disease, which is basically a parasitic infection by Trypanosoma cruzi. Okay, Chagas disease. Rarely bacterial, rickettsial, fungal, protozoal, and parasital. In bacterial, I would definitely need to mention this one, diphtheria. Okay, Corynebacterium diphtheria. And in viruses also, you need to definitely remember even dengue in our country, because this was taken from past textbook. Dengue you need to remember, and quite actually rickettsial is quite rare, but in some endemic areas where there are forests, where there are ticks, and regions, some regions have more prevalence of rickettsial infection. Definitely you can expect rickettsial myocarditis, okay, because they will see a lot of severe form of the cases too. Okay, so till now you have understood a bit about the etiology, the pathology, and the that. And sorry, I have not spoken about the non-infective causes. Let me talk about the non-infective causes. First thing, immune mediated myocarditis, like what? Kawasaki disease, okay, acute rheumatic fever, Kawasaki disease come under immune mediated diseases. Then collagen vascular disorders, and there is something called as toxic myocarditis. Okay, actually sometimes diphtheria is counted as toxic myocarditis and not exactly due to the infective cause, because it is a toxin which is causing the thing. So for example, the diphtheria exotoxin, right, it could be included in infective this. Another drug mediated, any drugs may cause. Then definitely our in scorpion sting, snake envenomation, okay, all these things can also cause myocarditis. All right, so that's it. These are the more common causes. You can just have a look. Yeah. Now coming next to the clinical manifestations. Okay, now this I'll be teaching in some headings, like how we exactly go through the a case. So let's say first, history. In history, what all you'll notice? Very sorry. In history, what all you notice? In history, in older children especially, because the most common cause is virus, there may be a history of upper respiratory tract infection. Okay, history of upper respiratory tract infection. In newborns and infants, the history may be of sudden onset. Okay, and it may be having presentation like anorexia, vomiting, lethargy. Okay, a sudden presentation of circulatory shock because of myocarditis. So this may be there. Okay, a very sudden onset may be there in infants and newborns. Okay, this is about the history. Coming to examination. In examination, it will depend on patient's age and whether the disease is acute in nature or chronic in nature. So based on this, we can, there will be some examination findings. Now let's say neonates and infants. Neonates and infants, signs of CCF may be present, that is congestive cardiac failure. Okay, that is poor heart tone. Because of poor heart tone, tachycardia, okay, gallop rhythm, okay, and tachypnea, and rarely they may present even with cyanosis also. Okay, cyanosis. In older children, the presentation may be a gradual onset of CCF, not sudden onset, gradual onset of CCF, and maybe arrhythmias as well. Myocarditis may present as arrhythmias. Okay, and sometimes there may be a soft systolic murmur and irregular rhythms due to SVT or ventricular ectopic beats. Okay, and in case of viral hepatitis also is present concurrently, you may find some hepatomegaly, or in CCF there may be tender hepatomegaly. Okay, so hepatomegaly may also be a finding on examination. Okay, coming next to ECG findings. What will you see in ECG? You may see any one of these or a combination of what all. I am mentioning some findings. Low QRS voltages, ST T segment changes, okay, PR prolongation, then QT interval prolongation, okay, and especially arrhythmias may be present, any arrhythmias due to premature contractions. Okay, any radiological support you may need? Yes, definitely you may need some radiological support. Radiologically you may see cardiomegaly, which is one of the most important sign of myocarditis. Okay, most important sign of myocarditis. I am not saying this, Cardiology is saying this. Okay, and this cardiomegaly may be of varying degrees. Okay, cardiomegaly. Then coming next to echo findings. Okay, in echo you may find cardiac chamber enlargement because of impaired function, impaired drainage and impaired function, impaired LV function, often regional. Occasionally there will be increased wall thickness, okay, and LV thrombi also. Okay, coming to few lab studies which can be done. What levels can you test in myocarditis? Cardiac troponin. Cardiac troponin. Okay, that is troponin I and T. And then you can test for myocardial enzymes. Okay, cardiac troponin levels I have told. You can even test for myocardial enzymes like CPK, especially CPK-MB. Okay, CPK-MB may be elevated. Now, just to mention a few points, normal in children, normal trop I level is usually less than equal to 2 nanogram per ml. Okay, there is something called radionuclide scans also which can do. In radionuclide scanning, you can go for gallium 67 or technetium 99M. Technetium 99M. This will identify the inflammatory changes, necrotic changes which are suggestive of myocarditis. Inflammatory and necrotic changes which are present in myocarditis. And last but not the least, in this endomyocardial biopsy, which is said to be the confirmatory. You know what is confirmatory? Doing biopsy, but who does it? Nobody does it. Confirmatory. Okay, confirmatory is endomyocardial biopsy. Okay, so this is about the basic clinical manifestations with history, examination, ECG findings, radiological findings, echo, lab studies. Okay, coming next to natural history of the disease. How does the disease progress? What to do? What's going to happen? Okay, and what is the prognosis? So the mortality rate can be as high as 75% in whom? Symptomatic neonates who are having acute viral myocarditis. Acute viral myocarditis in symptomatic neonates can be as fatal as out of 4 neonates 3 will die. Okay, it's that bad. Majority of patients with mild inflammation recover completely. Mild inflammation. So these are the ones which are having mild myocarditis, which are mostly subclinical and sometimes even not even detected clinically. They recover completely. Some patients go on to develop something called as subacute or chronic myocarditis, which may lead to persistent cardiomegaly. This may be present with or without CCF. Okay. In the ECG of these patients, you may find evidence of left ventricular hypertrophy or biventricular hypertrophy also. Biventricular or left ventricular hypertrophy you can see, who develop subacute or chronic myocarditis and persistent cardiomegaly. Now, sometimes myocarditis may be clinically indistinguishable from dilated cardiomyopathy. Clinically, sometimes. Okay, and sometimes myocarditis is said to be a precursor of idiopathic DCMP. Idiopathic dilated cardiomyopathy, myocarditis is a precursor. Okay, this is a little about the natural history and prognosis wise. Next we will be talking about management. Okay, till now it was all little bit clear, right? So you have a bit idea about the prevalence, the etiology and the clinical manifestation, pathology and everything, and then we discussed about the natural history a bit. Okay, coming next to management. In management, some say basically this is a textbook point, but virus isolation from cultures of blood, stool or throat swabs is useful. Throat swab or throat wash. Okay, blood, stool and throat washing, virus can be isolated, and you can pair paired sera, you can see like acute sera and convalescent sera. okay, should be compared for increasing titers. Okay, you know, right? Paired sera count, that is acute sera and convalescent sera we will be doing. And this was a little bit about the investigation wise, what is the things you can do. In the management or treatment per se, you should definitely first go for bed rest. Principles of management of myocarditis. First is bed rest. Second is limitation of physical activity. Even if bed rest is there, there should be limitation of physical activity. And we can go ahead with something called as anti-congestive measures. Anti-congestive measures. So what are the anti-congestive measures? You know, basically for CCF, rapidly acting diuretics. So like furosemide 1 mg per kg, 2 to 3 times a day, 2 to 3 times per day. Okay, furosemide you can give. Then you can act rapidly acting inotropes like dobutamine or dopamine. Okay, you can put, which is useful in critically ill children, but this you should see whether it's a hypotensive CCF or a normotensive CCF, in which details I'm not going to go because it's not a class on CCF or cardiogenic shock. Okay, so dobut and dobutamine will be trying for the inotropes, okay, in critically ill children. Okay, and very sorry, yeah, very sorry, oxygen should be provided to the child. Oxygen, okay, oxygen is very useful. And there is something called as cardiac chair or infant seat, which you can use. Cardiac chair or infant seat, which relieves the respiratory distress. Okay, it's basically a more comfortable position for the child. Okay, so it will relieve the respiratory distress. All right, oxygen, bed rest, rapidly acting inotropes, dobutamine, dopamine, and rapidly acting diuretics like furosemide. Digoxin, some centers use digoxin. Okay, some centers, and some centers have stopped using digoxin now. Okay, digoxin now we are using, even if you are using only half of usual digitalizing dose. Okay, digoxin. Now recently there's a new therapy which has been added, that is IVIG. Recent means not recent, means yesterday, 1 year. Recent times we have started using IVIG, especially which is refractory myocarditis, or in which you are suspecting an immune mediated causes like Kawasaki disease. Okay, we are using IVIG, which is 2 gram per kg over 24 hours. 2 gram per kg over 24 hours. In acute phases, you may use ACEI, that is ACE inhibitors, okay, which is captopril in acute phases. Okay, and for arrhythmias you can use IV amiodarone, which is done, very aggressive treatment of arrhythmias needs to be done. Okay, role of steroids. What is the role of steroids? Can anyone tell me? Steroids are used in rheumatic myocarditis. Okay, steroids are used in rheumatic myocarditis, and specific therapies like antitoxin therapy is used in diphtheritic myocarditis. Antitoxin, diphtheritic myocarditis, you can use specific therapy. Okay, diphtheritic myocarditis. So this was more or less about our treatment of and obviously if the case has having respiratory failure, definitely see respiratory support every time. ABC always comes first. Okay, now it's CAB, circulation, airway and breathing, definitely that you have to manage. Okay, so you have to be careful when, like, if required, ventilation of the child. If metabolic acidosis is present, treat the metabolic acidosis. If required, you have to treat some metabolic problems like electrolyte disturbances or some calcium disturbances, whatever. Like, see, you have to treat the case as a whole. You cannot just say, okay, myocarditis. The case won't come simply as myocarditis. The case may come as a myocarditis with CCF, with respiratory failure, with septic shock. Okay, a picture may be mixed, and you may have to be a very complicated management. Definitely this should, and any such cases should be management should be done in PICU in the PICU side, that is the ICU room itself, or PICU bedside, where you can monitor, where even if you're shifting it to a more stable ward under the PICU, monitoring should be done very aggressively. Monitoring is very important. You should keep a chart of how the pulse rate, how the heart rate is going, how the saturations are maintaining, if the patient is going into shock, if everything. Okay, you need to keep an eye on everything. If the respiratory distress is there, if oxygen is required, what is the ABG parameters, everything. So this has to be definitely, that is my take home message. Okay, this is just a simple topic I have approached, but definitely the management is could be a tricky. Okay, I have seen many cases of myocarditis die because they reached very late to us. They come to us in a very end stage of CCF, referred to us after many days of ill management by some peripheral hospitals. I'm not blaming them, but ill management in the sense they didn't have the required infrastructure or whatever. So yeah, so basically it's not something which can be taken easy. It's very common to find myocarditis, especially in a country like India, in a setup where there are a lot of infections, infective causes like viral myocarditis, bacterial myocarditis, rickettsial myocarditis, dengue myocarditis. These are all quite common still. Kawasaki disease, rheumatic myocarditis, these are also common. Okay, so you have to just keep a lookout. Okay, now recently COVID has also come. COVID and MISC related myocarditis. Yes, so keep an eye for all these cases. Keep your eye broad. Keep a watch on everything, the vitals, the signs, symptoms of this child is showing, intervention, whatever you're doing, what is the result. Okay, end point of your intervention. Keep titrating your treatment according to the response of the patient. Don't overload the child with fluids. Don't underload. Don't give less fluid so that the patient still remains in shock. Keep the child well hydrated, well maintained, BP well maintained. Diuretics should be used correctly. Inotrope should be tapered or upgraded correctly. Okay, oxygen. Okay, whenever required oxygen, you need to assist. Okay, so this is a multimodal management. Definitely this management should be under a PICU level only. Okay, so this is the end of my class on myocarditis. So yeah, thank you so much. So this is Dr. Waheed Hussain. Okay, and the source of this was Park Cardiology, and yeah, it's a very beautiful book. For you can read these three things like infective endocarditis, rheumatic endocarditis, rheumatic heart disease, infective endocarditis, myocarditis, pericarditis, and all these things you can read very beautifully in this book. Okay, so yeah, thank you so much. See you next time. Okay, thank you.